Okay, we're live. I think right now we're live. This is Elliot Fishman, and welcome to Facebook. No, we're not on Facebook. We're on YouTube. That's the whole point. We're trying to change YouTube, so that's why I wore a gray shirt. I always wear a black shirt, and we're live. I visited my grandchildren this weekend, so if anyone needs any art or anything, I got a few extra incredible pieces of art, and this one's from Sam. Max and Sam. So if you need if anyone's short art for their office, just give me a call, and you have to call us soon because it's first come, first serve, and art like this just doesn't stay around all that long. And this is a 5, I think. Right. Okay, good. He's not 5. He's gonna be 3, but he's not 5. Anyway, I'd like to welcome everybody, and we are trying to do some YouTube Live, and Lily has it all set up. So all I do is I have to press a button, and we schedule it, and we're going to try to do it. Again, I mentioned last time we have 33,000 plus subscribers of YouTube, and we are trying to expand what we have. We have thousands and thousands of lectures and cases and all sorts of great things with video, which is what YouTube is, and we're trying to improve that. So we're trying to make that better. And now I moved the screen over. My eyes are in the center, not like I'm looking to the side or something. There's some great art behind me there. Anyway, this is on renal cancer or renal masses. So I think the thing to recognize is, I'm going to just give you a few pearls on the kidney. 1, if you're evaluating hematuria, you must do non-contrast scans. If you don't do non-contrast scans, you'll miss stones, but also your ability to determine the density of a lesion, which can help you predict whether it's high-density cyst or simple cyst or cystic tumor or papillary versus clear cell. Having the non-contrast can be very helpful in that regard. So you must do non-contrast. I'm not saying you need to do non-contrast, particularly a younger patient, all the way down through the pelvis, but you need to do non-contrast studies. So that's 1. The second thing is, if you're doing patients over age 35, where radiation isn't such an issue, then you want to be doing arterial, non-contrast, and arterial, 30 seconds, venous, at about 70 to 80 seconds, and then delayed about 4 to 5 minutes. Now, several points to make. The reason I like arterial is it gives you good vascular mapping, which can become important for surgical planning, but also the vascularity of the lesion. If a lesion's above 120 or 130 Hounsfield units, then it's probably going to be a clear cell renal cell carcinoma. Under 90, it's going to be a papillary. And you'll be right using those numbers 90+% of the time. Also, things like oncocytomas, chromophobe lesions can potentially be better defined because of their enhancement on that early phase imaging. Now, the venous phase, of course, is mandatory to look at the renal vein. When you have extensive renal vein and IVC involvement, the arterial phase can be very helpful, showing you the extension. But the issue, of course, is that if you're too early, hard to distinguish clot from just lack of opacification. So you really need to be in the venous phase. So 70 seconds is a good number to be at. If you went to 80 seconds, that's not bad. I think under 60, probably you haven't waited long enough, and that's not a good place to be, okay? So that's venous. And then expiratory phase is mandatory. I've seen lately where people would say, well, we don't need expiratory phase. That's nonsense. If you don't do expiratory phase, you're going to miss a lot of transitional cell carcinomas. Transitional cells may present simply as filling defects in the calyces or narrowing of the calyces. In order to detect smaller lesions, you need to have the calyces opacified. It takes at least 3 minutes, typically 2 to 3 minutes for that to happen, and you want good opacification. So doing that at about 4 minutes works really well. You can do it at 5 minutes. That would work well also. If you go beyond 6 or 7 minutes, the problem is the contrast gets so dense in the calyces that it gives a blurring artifact. You get beam hardening artifact, maybe is a better way of describing it. And with beam hardening artifact, it's very easy to miss things. So if you have a small transitional cell carcinoma, but you have beam hardening artifact, there's a good chance you're going to miss the lesion. Okay? So don't be too early, don't be too late. You got to be at the right time. The other thing is when you're looking at excretory phase imaging in the calyces, If you only look at the axial images, if there's a big lesion present, you're not going to have a problem. But if it's a small lesion with a stricture in the calyx, narrowing of the calyx, if it's papillary necrosis, or anything that involves the calyces but may be somewhat subtle, you can miss it on looking at the axials. When you look at the coronal, you can really see everything like it's supposed to look and follow the calyces and look for any changes. Now, the other thing is you don't only want to look at the axial images or even the coronals. Those are good, but as far as I'm concerned, not good enough. So what you really want to have, and this is critical, there's no way around it, is do at a minimum, I was going to say do 3D imaging, which is ideal, but at a minimum do MIPS. Do a bunch of sliding MIPS even through the calyces, and then you're going to see the papillary necroses, the calyceal stenosis, the calyceal irregularities, and you're going to pick up the small tumors. If you don't do that, you're going to have all sorts of problems. Now, another thing is, of course, in terms of 3D, looking at arterial mapping, whether it's renal donors, renal artery stenosis, fibromuscular dysplasia, or renal cell carcinoma staging and planning, 3D mapping is ideal. Combination of volume rendering or cinematic rendering and MIP works very nicely. Okay, that's good. And then, of course, the ability to also go from there to use some of the other things like interactive modes and stuff. But you need to be able to look at things more aggressively so as not to miss tumors, but then when you have tumors, to be much more accurate in terms of staging tumors. So that also becomes very, very important to me. So people do have this tendency to think, oh, I know how to do cancer. I know how to do kidney specifically. The answer is most people don't. The studies we see on the outside, and we all know if there's a study that's done incorrectly, it's always an outside study. Now, of course, sometimes you look at the outside study is done at one of your outside sites. Then you say, oh, dear, I am the problem. But the reality is that people do cut corners. They just don't think it out. And the protocols are not set up correctly. Look at CTisus. Look at our webpage. Look at the protocols for kidney. You need to do that to be able to do things well. So that becomes very, very important. And again, 3D mapping is really good for looking at the ureters. Now, also in terms of kidneys, what else can I tell you? The vascular enhancement, clear cell versus papillary, high accuracy, use 120 as a cutoff. Typically, papillaries are felt to be under 90. You can't use size. I've seen some huge papillary and I've seen small clear cells. And if you have central necrosis, people ask me, do you measure inside or the rim? I measure where the enhancement is the greatest for the most part, just because you can have cystic renal cell carcinomas that are clear cell, but the cystic component's in the middle. And if you measure that, it's under 100, but the periphery is enhancing to 200 or 300. So you need to do that very, very carefully. So that becomes very, very important. I see on the, you can ask me questions in our chatting. CTisus, which means Lily, has popped up our protocols where you can go there and find them. And as Gashem said, hi. What else can I tell you? That's about the main thing, because I want to make these very, very focused. One thing we are working on is the equivalent of TikTok videos, 1-minute pearls. I'm working on that. Hopefully I'll have some of them for next week that Lily will post. Also, we want your feedback on YouTube. What can we answer? We can do quick cut and paste or just come and speak with you. We're doing that. We're doing lots of really, really good stuff. I also will say, I'll take this time to say, not that it's any great surprise, but we are very supportive of all our friends in the Ukraine. There are many CTisus users, but whether you use CTisus or you don't, whoever you are in the Ukraine, you have our support, the bravery, and just all the people. And we hope that Putin and his friends kind of see the light. I think his army really doesn't want to fight the Ukrainians, which are their basic brothers. Kind of seems like 1861 all over again with the Civil War. That never turns out well. So hopefully Putin they'll give him a way out, where, because people like Putin and It's never easy to say, oops, I made a mistake. Give me a reset. Give me a do-over. Give me a mulligan. There's no mulligans, okay? And so if he needs to figure out how does he get out without losing face, without losing his job. They don't want it to be Afghanistan all over for them where they spent 10 years and it went bad. Um, Here it's going bad very quickly, but the reality is, as you know, Russia has tremendous firepower. If they want to flatten Ukraine today, they could. I don't think they will, but I think it's going to be a problem. And the other thing is, all of us need to give our prayers and our support to the Ukrainian people and the government. If you want to see lessons in leadership, it will be written about for the next 50 years how their president basically did not listen to the US and Britain and leave the country, but he stood there basically in a bunker leading the fight. And I think when you have a leader who's sitting in the bunker, knowing he's at high risk, but knowing he is there to support the country and its freedom, very, very hard to argue about that. And, I think the world has come together. It's a terrible way to have to get together, but hopefully things are going correctly. So with that, I thank everybody for their attention. You have any questions, just give us a call and we'll be happy to answer them. And with that, have a great day.